real-time situational awareness that can guide public health action during a climate event, and also 2, for building capacity through emergency simulations. So just a quick agenda to get us all on the same page, show you where we're going to go with this. First, I'm going to introduce our team here in Kingston and showcase the breadth of the work that we do. Then I'm going to quickly outline public health approaches to climate change. And this, of course, focuses on surveillance of health outcomes. And in this case, we'll introduce the concepts of traditional versus syndromic surveillance and give you a bird's eye view of how our syndromic surveillance works and what value it offers to monitor climate change impacts, especially as a real-time tool for number 1, that situational awareness piece, and 2, for emergency preparation. So KFL&A Public Health is a local public health agency in Ontario. And for those of you that don't know, Ontario is divided into 36 public health agencies of varying size, population, geography, and we are located in the southern region with head offices in Kingston. And we're about midway between Ottawa, Montreal, and Toronto. And we just really had the fortune of having some forward-thinking leadership in the 2000s start putting some girth behind putting together the Syndromic Surveillance Project. And it's a project that started with just a handful of our local hospitals, but now we're up to near coverage of the entire province, but we'll talk more about that in a little bit. But this work with Syndromic Surveillance has driven the development of a team of health and information professionals that I'm showing here in this slide. We've grown into a really multidisciplinary team of specialists in healthcare, life and physical sciences, statistics, IT. A large part of our work that we do here in our agency is our in-house public health program evaluations. But we also work with e-health applications, GIS mapping, and various research projects. Our e-health applications span the entire health system, from our Syndromic Surveillance System, or the ACES, that we're going to be talking about in more detail in a little bit, to SHIP, which is the Southeast Health Integrated Information Portal, and it serves as a database for patients as they interact with different healthcare systems from primary all the way up to tertiary care. And finally to PHIMS, which we'll talk about in detail as well, which is that situational awareness tool. And today we'll talk about it in terms of climate change applications. Why the focus on climate change? Well, we really see that those of us in the environmental public health field are uniquely trained and situated to provide the leadership our communities need to build resilience and adaptive capacity. As evidence to that, the most recent revision of our Ontario Public Health Standards are increasing the local public health board's responsibilities regarding the impact of climate change, and specifically requiring local assessments of vulnerabilities and adaptive capacity. This, in part, is driving our team's focus on creating tools to assist health units to meet these requirements. So, briefly, what impacts are we talking about? This is a really helpful infographic from the US CRP paper back in 2016 that really describes the scope of the impacts. At the center of the diagram, you see these human figures representing adults, children, older adults, people with disabilities. The left circle are all those climate impacts like air quality, wildfire, sea level rise, storm surge, heat, storms, drought. And finally, on the right is all those impacted health domains: medical, physical health, mental health, community health. So it's a huge scope of impacts that we're talking about when it comes to climate change. So in the language of our Ontario Public Health Standards, the public health approach to community or population health is guided by emphasis on 1, healthy behaviors, 2, healthy communities, 3, population health assessment, and 4, the social determinants of health, or that guiding principle for all our health program, public health programs, that they be targeted to reduce issues of equity within our communities. So our focus for climate change should therefore be on assessment and surveillance of health impacts and the capacity to be resilient, as well as a means to promote, protect, and prevent climate change impacts, and also on preparing for emergencies and management of emergencies as they occur. So the goal for us at KFL&A Public Health is to do as the WHO is doing, and that is to rebrand climate change as a health issue and acknowledge the potential impacts that future climate events will have on our populations, especially our most vulnerable. Therefore, we are working towards several surveillance initiatives, including the development of syndromic surveillance protocols specifically for health indicators associated with, for example, extreme temperature, or reduced air quality, or flood risk, and working with our PHIMS application to strengthen our real-time situational awareness capabilities, and also focus on building tools to promote emergency preparedness. So I've been talking a lot about syndromic surveillance. We are going to spend some time explaining what that is, and it's best described within the context of public health surveillance. So to be on the same page in terms of definitions, I offer this definition of public health surveillance, and that is, it's the ongoing and systematic collection, analysis, and dissemination of health-related data with the goal to reduce morbidity and mortality by informing public health action. So traditional forms of public health surveillance are things like surveys or monitoring hospital or physician records. And these types of surveillance allow us to understand disease trends over time. In contrast, syndromic surveillance is public health surveillance that uses real or near real-time pre-diagnostic data and statistical tools to detect unusual health patterns or signals with the goal of reducing the time to detect and respond to outbreaks that will be of public health concern. So just to make it clear, though, this term syndrome refers to the surveillance of, syndromic refers to the surveillance of syndromes or a predefined grouping of symptoms or health indicators that may indicate a clinical diagnosis or specific health outcome, but do not require laboratory diagnosis for confirmation. The key features of traditional versus syndromic surveillance are shown here. The data sources for traditional are things like diagnostic data from case reports, laboratory reports, whereas for syndromic surveillance, we're looking at pre-diagnostic data, so things like triage records, drug sales, school records. So that really affects the timing. Timing for traditional is things like days to weeks, whereas timing for syndromic can be immediate, and that's real time, to hourly or daily or near real time. And the goals are different as well. So the goal for traditional is monitoring individual cases or clusters of cases, whereas for syndromic, the goal is to identify excess or unusual case counts. And finally, the data transfer are different as well. For traditional surveillance, we can rely on maybe even paper records or vetted electronic records, whereas for syndromic, we're looking at automated electronic data transfer. So this graphic may give you a better sense of the improvements in timeliness that syndromic surveillance affords. The timeline of an outbreak is shown as the red arrow, and the possibilities of data sources that could identify that outbreak are shown as we move along in time on that timeline. So the pink box indicates exposure, and the blue box shows us different data sources that syndromic surveillance can access, whereas the gray box are those traditional sources of information. So syndromic surveillance is trying to capture those pre-diagnostic health-seeking behaviors, such as buying over-the-counter medications or calling a nurse helpline or even going to the emergency department. If we can capture that data as it happens, we may be able to identify excess activity and activate public health action before an outbreak becomes excessive or overwhelms local health care. So now let's put this in context of what it looks like for a climate event like extreme heat. You can see that as the severity of health effects increase, generally the proportion of the population experiencing that health effect decreases. So the most sensitive signal may be mortality, but that will hopefully be rare, and we may miss the true impacts of that heat event on a population. On the other hand, less severe impacts are common, but difficult to measure. That said, there are viable syndromic surveillance applications using Twitter or Facebook or even web searches. but our approach is to measure those seeking acute care. So now, just to give you some details of our syndromic surveillance system here at KFL&A Public Health, I'm going to pass the mic over to Dr. Paul Belanger to outline our ACES system.
Great, thanks, Nancy. Good afternoon, everyone. So I'd like to just spend a couple of minutes reviewing our Acute Care Enhanced Surveillance System. It's a program that's been in operation since about 2006, operated here out of KFL&A Public Health. It started with, just believe it or not, 3 local hospitals, 2 in Kingston and 1 in a town called Napanee just down the road. And it's gone from 3 hospitals over the last decade or so to providing almost geographically exhaustive coverage across the province. I think we're now up at 160 hospitals. So this is our log-on screen for ACES. As I said, we've got about 160 out of 170 acute care facilities in Ontario belong to the ACES system. And it's just as Nancy described, it's really about the real-time collection and analysis of patient data. Clearly in real time at triage, we don't have diagnostic data. What we have is what's called a chief complaint. So you would show up at the emergency department, you'd be assessed in triage, and a triage nurse would code your chief complaint as, broken leg or stomach cramps or syncope or whatever the case may be. What we do is use what's called natural language processing to convert those free text chief complaints into one of 84 different syndromes that we monitor. Some of them are very important for early public health response, and we'll look at a couple of them. And some of them are more general syndromes that are perhaps less relevant to public health monitoring. On any given day, we're getting about 18,000 emergency department visits from those 161 hospitals all across the province. And on any given day, we're getting something around the order of 3,000 inpatient admission records. So that data in real time, when you show up at triage and your triage record is entered by the triage nurse, when the enter key is hit on the keyboard, we, within a second or milliseconds, we get a copy of that record here in our data center in Kingston. It's fully de-identified. It contains a very, very small packet of information. Just has the patient's gender, the patient's age, portion of their postal code, and most importantly, it contains that field I described already called the chief complaint. And the way that we're using this system, using some of these automated routines, is really trying to tease out whether there's any evidence of a threat to public health. So we're looking for GI outbreaks. As Nancy's going to talk about later, we're trying to see if there are manifestations of extreme heat events or other kinds of adverse weather events. But it's real time. It's 24 hours a day, 365 days a year, fully automated. When our alerting systems detect aberrations or detect excess volumes, we have automatic notification to epidemiologists all across the province. We don't, clearly, in Kingston, we can't do the investigation here. So we notify the local epidemiologist, the local public health unit, where the aberrant visit volumes are coming from, and they take it upon themselves. It's their responsibility, effectively, to investigate that further. I mean, it could just be statistical noise. It just could be, the vicissitudes of particular data flows or particular patient visit volumes that day. But that deeper dive is undertaken at a local public health unit. I won't go through the whole data flow, but again, the fundamental idea here, step one, is that the patient arrives at the acute care hospital, they're triaged, their basic information is recorded in the triage record. Then, before the data is sent to us, it's scrubbed of any personally identifying information. It comes into our data center over a secure pipe that only participating institutions are allowed. It doesn't go over the public internet. It comes in on a secure pipe. And then once it's in our data center, then we apply our suite of analytics and aberration detection to it. If there's statistical evidence of something that's aberrant or deviant, then, as I said earlier, an automated alert is sent to the epidemiologist or the local public health unit where the aberrant case counts are taking place, and then they, in turn, investigate the matter further. So this is one of our syndromes. This is what we call the environmental syndrome. This is just a word cloud to help our end users and help epidemiologists understand the nature of that syndrome. So as Nancy said before, we have 84 of them. This little pictogram here is just one. We use, as I said earlier, natural language processing to bucket them, to take a chief complaint. Because remember, the chief complaints aren't standardized. They're free text. It's whatever the triage nurse enters. There's spelling mistakes. There's uppercase, lowercase. Sometimes there's not consistency in how they're entered. So you can't really use string matching techniques. You've got to use more advanced techniques, such as natural language processing. So all of those 18,000 records that come into our building throughout the day, in real time, we run those NLP, those natural language processing routines on them, and we bucket them into one of the 80 syndromes. Then our team here, our data scientists and our research associates, people like Nancy, do quite a vigorous validation exercise. We pull the NACRS data, the National Ambulatory Care Reporting System data, to make sure that the way we're classifying visits using only the chief complaint nicely lines up with what eventually gets reported through NACRS. This is just some of the syndromes. I'll just let that stay up on the screen for a few seconds. These are our 84 syndromes. So imagine again, 18,000 records. Those chief complaints are populated in 1,000 different ways. And what we try to do is reduce all of the complexity of those chief complaint fields into one of these 84 standardized syndromes. And then we monitor them. We monitor the visit volumes for each of these 84. We have historical baselines, and we have other kinds of statistical routines that I won't bore you with right now. But when we detect an aberrant number of admissions in one of these 84 buckets, then again, we notify in real time the local epidemiologist, the local public health unit, to dig a little further. This is just one of the many screens in ACES. This is what we call the EpiCurve page. And this particular page, this happens to be our jurisdiction. This is the KFL&A Public Health unit. And what we're looking at here are total visit volumes by day in our health unit over a 1-2 week period. These are for all genders, all ages, looking at all syndromes. So, the epidemiologists, the end users of this tool, they can look at longer time spans. They can slice and dice the data by gender, by age. They can overlay it with moving averages, standard deviations, and it really gives them a drill down capability to be able to understand visit volumes at local acute care facilities. So that's going to segue nicely into some more information that Nancy is going to share with you about how we use syndromic surveillance, the ACES system, in order to understand environmental health threats. But before I turn the floor back over to Nancy, I just wanted to outline a couple of other products that we've developed using the ACES system as a data feed. So one of them is called ILI Mapper. Influenza-like illness mapper. It's a very simple tool. It's out on the public internet. There's no password required to use this tool. And the idea is, again, because this is real-time data, this is not delayed data. We're not looking for formal diagnoses here. We're not waiting for NACRS or DAD data, but in real time, every week or at any interval we want, we can share with the public and share with public health partners information about the spread and diffusion of influenza-like illness across Ontario. We've had this tool up for, I think, about 4 or 5 years now, and it's used in local planning. We know there are a lot of hospitals across the province that use this tool in order to anticipate when local communities and different locales are going up the curve in terms of visit volumes in anticipation of influenza season. Another tool that we've built, again, using this wonderful data source of ACES, we've got, again, 160 different hospitals feeding data into ACES. Another product that we've developed is called the Ontario Acute Care Surge Monitor. And the idea here is because we're getting real-time visit volumes from every hospital, we can give the province of Ontario and our provincial partners like the ministry, we can offer a sense of the degree to which the acute care sector is experiencing stress. Our visit volumes, for whatever reason, are they exceptionally high? Are they trending towards, so-called surge status at any given particular time? Again, so it's not, delayed 24 hours. It's a real-time, literally, when I say real-time, I mean real-time snapshot of visit volumes as they're occurring, and the ministry and other partners can monitor this site and they can understand where those stresses are taking place. Is it across the acute care sector? Is it in particular locales? Is it for particular kinds of visits, particular age demographics? And we think it provides a nice measure, a better situational awareness of what's going on in the acute care sector across the province. Again, I'm sure across the country, we're all facing the opioid epidemic. One of the things we can do with this ACES data, again, and we can do this in real time, we can look for overdoses and opiate toxicities in that chief complaint data that we get, and we know that there are measurement errors, considerations. But again, you can't wait weeks and months to get full diagnostic data. So we're leveraging ACES to try to provide as timely a signal on what's going on with the opioid epidemic as we can. And this has been well received by the public health community across the province, and number, widely used, and a lot of other agencies are looking at this tool as well. And if there are interventions, if there are particular interventions that are being fielded, hopefully this kind of a tool is going to provide a little more timely evidence on the efficacy of those interventions, assuming that part of the intervention is designed to reduce visits and admissions to acute care. So I think with that, I will turn the floor back to Nancy and let you take it over.
Thanks, Paul. So yes, so back to our GIS-based system, that being PHIMS. So we are focused on developing tools to improve the surveillance of climate change impacts. And again, that is with this two-pronged approach that I talked about earlier, and that's based on one, that's situational awareness, and two, emergency preparedness. So in both cases, we're able to improve surveillance that is generally available regarding meteorological and environmental information, but we add to that socioeconomic indices, and most importantly, those health outcomes from our ACES product. So the PHIMS application looks like this, and I'm sure that you're all fairly familiar with these map-based applications. I apologize for the Southern Ontario-centric focus of this screenshot, but if we had the application open, you could see that you could back right up and you can get a provincial view, and even if we have the data for a national level view as well. So the layers that we have available at this point for display in PHIMS are shown in the menu on the left. We have administrative boundaries, which show, for example, the various local public health unit boundaries. We have various air quality indicators included, and just should mention these are all, we're not obviously gathering this data or generating this data, we're just pulling this from Environment Canada, and that's generally in real time. We have a whole bunch of different demographics available as socioeconomic indices, and these, we get that information from Statistics Canada. We have emergency management information, like the location of fire departments, location of healthcare facilities, and there's that health outcomes box there, where we can display real-time syndromic surveillance information. Also below there, you'll see temperature stress, and that's, again, available in real time for Environment Canada. So any or all of these information can be layered on top of the map and monitored during an event. So for some examples, we click on the Southern Ontario alerts, and we'll get these displayed on the base map. They're clickable for more information. Likewise, get into the temperature stress box, and we see a bunch of different temperature parameters. You can see in this screenshot that I have backed up to see a good portion of Canada. These are data pulled from Environment Canada, so we can display as much across the country as we can. We can likewise display map cloud cover, what else is on there, dew point, information from specific local sensors, relative humidity, wind speed, direction. Oh, we also can pull in products like this, like fireworks. We can see smoke plumes across Canada, so really important during wildfire seasons. And we can compare that at the same time to this, the AQHI, or any of the other air quality parameters that we've included. You know, you can look specifically at nitric oxide, PM 2.5 or 10, and again, all pulled from the Environment Canada sensors. So, you know, through their modeling process for the country, and is near real time or near real time as they are providing the information. You can also even click right down to a local sensor and get the detailed information from that sensor itself. So in this example, we're looking at Oshawa's sensor, and you can get the local AQHI readings. Just, you know, I'm sure you guys have figured out by now that these are screenshots from several months ago, so they're definitely not showing what's happening today. But if we opened up the actual application itself, you get to see what the conditions are right now. We can also add in layers of data of essentially anything that can be geolocated. For example, here I'm showing the location of hydrometric stations. So drilling down to each of those stations can open up real-time readings from that station on water levels. Could be helpful during flood conditions. Here I'm showing healthcare facilities. In this case, it's hospitals and pharmacies in the Kingston area. And we've also included in the system too is this our in-house model of urban heat islands, and we've done this urban heat island modeling for all the larger cities and municipalities across Canada. And we actually did this modeling work in-house. It's based on satellite imagery from hot summer days. But just to note that it's from satellite imagery, so we're not talking about you know, experienced temperature at surface, but we're actually talking about the actual land surface temperature, which can be a proxy for the experienced ambient temperature. So finally, just wanted to show this last slide, and finally we get to that health outcomes. So we can toggle all those different information with this real-time data from the Syndromic Surveillance System. In this slide, I'm showing a screenshot for the city of Ottawa from a couple summers ago during a hot weekend. So the way that the health outcome data is displayed is that what we're showing here is that Enviro syndrome. So it's the number of ED visits that are categorized as heat-related or Enviro, and they're aggregated to geographical areas. In this case, it's the FSA level of geography. And we display them as either above average, and that's the reds, or below average, and those are the blue colors. So this data is de-identified, so personal health information is not being shared, but we can get a sense of the health impacts occurring in a specific geography and relative to the other geographies. So hopefully having all those different layers of information displayed together can lead to much more effective and targeted and timely public health action. But also that's what's important for public health action is that equity approach. So for a health equity approach, public health officials can map demographic information and layer it with those health outcomes. And we can see if there's a greater health impact in areas of greater vulnerability. In this case, in this screenshot, I'm showing the deprivation index, which describes material wealth or the material deprivation index. You see in the menu on the left, we've got a range of different indices that we have made available in the PHIMS. We update these as Statistics Canada updates their information. We can display demographics from a number of different measures, such as that social or material deprivation index, and also the Ontario Marginalization Index. And also, we've also included some what are maybe typically vulnerable groups, such as age groups of children, or the concentration of children under age 4, and also older adults. So the first application of PHIMS that I wanted to sort of point out for climate change is this situational awareness piece. In fact, much of the work that we have shown here and that we have with PHIMS was actually developed for use with the 2015 Pan Am Games in Toronto. And PHIMS and ACEs were used collectively to provide situational awareness for the Toronto area during the Games. So we developed our environmental syndromes for use at that event. But it can be and has been used to monitor other mass gathering events. It's been used for emergencies such as major fires, in prep for heat waves or extreme cold events. So I just want to point out, though, if you are interested and would like to take a look, please register for an account there on the website. Just follow the instructions at that website. For those of you outside of Ontario, we'd be happy for you to take a look at it anyway, even though most of the information we're displaying is for Ontario. If you're interested in learning more about it, just contact us and we'd be happy to talk to you about it. And if you are in Ontario and you're not using PHIMS, please do contact us for registering and getting an account. We'd be happy to walk you through and do some of the training. And we're really hoping to improve our training materials so that more health units in Ontario can use this tool and we can develop better emergency management tools with it, and specifically for climate change adaptation purposes. So that leads into that second application of PHIMS that I've been talking about, and that's in developing it for emergency preparedness, specifically through simulation exercises. So the recent literature really seems to support that the clearest route to building resiliency in health systems is through preparation. So that meaning simulations, not unlike military war games, and that this will probably be the easiest, most likely way to actually prepare us for what climate change is going to be bringing. So we have built a simulation tool using the existing infrastructure of ACEs and PHIMS, and we use data from both historical and projected public health incidents and emergencies. And we're actually using this currently to train public health medical residents. We did build some simple training modules in prep for the Pan Am Games, such as an extreme heat event, influenza-like illness outbreak, an explosion with mass casualties. And we have been working on more of these specifically for resident training, but we hope to be developing more in the context of climate change. But running these scenarios does have multiple benefits. We can train staff to use the tools and to manage emergencies, but more importantly, we can start to identify gaps in our resources and in our policies, or even vulnerabilities in our communities or our community resources. And then this knowledge can be used to strengthen and prepare our areas for changes that will happen, that we know are going to happen due to climate change. So just as a note, we do prepare these simulations using I'm sure the well-known, that you all know this IMS structure. And we give the trainees roles within the public health emergency management and different roles. And we also include training on the hazard identification risk assessment tool. We keep with the OPHS and also with our harmonized heat warning and information systems for Ontario. So it's a whole host of things that we can pull together in doing these simulations. So what do the training simulations look like? So I'm just going to show you a few slides of one of our extreme heat simulations. They are multimedia productions. We have defined role playing, and we also have a custom-built dashboard based on ESAs and PHIMS in which we inject and display the simulated data. And for some of the scenarios, the data will change according to the responses of the people in the exercise. So in this example, we are seeing a heat warning for the city of Barrie. My apologies to any residents of Barrie that may be watching this. This is just the simulated data. You see that we give the participants different roles according to like .IMS defined roles. We give them preparatory questions. And then the data is accessible through this PHIMS-based tool. We give them access to all that different information that I was showing you, actually that's available in the tool itself, at least that's relevant in terms of demographics, geophysical information. We add in different scenarios. In this case, we threw in a power outage. I think in this same scenario, I think we've got a marathon running at the same time. So we try to throw in as many different sort of wrinkles into the story as we possibly can. And then, of course, finally, we inject all that health outcome information too. So we do this as syndromic surveillance data. So in this case, we'd be showing the ED visits for the Enviro syndrome. We're showing them increasing steadily over the time course of the heat wave. So we've got a bunch of those different scenarios that we've put in place, and you know, we're really hopeful that we can improve these and develop some more that would be more specific to different climate change scenarios. But just to finish this whole talk up, it really was our hope to give you a general overview of the different climate change initiatives that we are in development, at our health unit. We really want to remain focused on that public health surveillance, and especially that added value of the product that we take care of at KFL&A Public Health, and that is the syndromic surveillance. But our goal is to build useful health products and to build capacity for public health agency across Ontario, especially as public health is taking on responsibility, more responsibility that is, to prepare our communities for climate change. So with that, I thank you all for listening, and we'd be pleased to answer any questions that you have on this presentation.
Thank you so much, Paul and Nancy. So we'll open up the floor now for questions from the room here at the BC CDC. So do we have any questions? Okay, looks like there's no questions in the room right now, but feel free to throw your hand up if you have questions later on down the road. So we'll go to online then. Nancy, if you could open up the chat box in the platform. So we'll start with the first question. So the first question is, what software do you use for your dashboard in ASUS?
What software do you use for your dashboard? Oh, so that's a great question. Thank you. So it's for the interface engine to move the messages across the wire, we use an open source product called Mirth Connect. Our data storage is done in a product called Microsoft SQL Server. Some of you would be familiar with that. And I think that what you're probably really getting at with your question is, what's the interface built in, the actual web application? It's custom built. It's using in JavaScript, using some packages. One's called D3, using a framework called Angular, but it's custom built by an in-house development team that we're fortunate to have here at KFL&A Public Health. It's not using a vendor product. It's built from the bottom up because it's a very specific application area, and to our knowledge, there really wasn't a vendor product that would allow us to do what we wanted to do, so we had to build it ourselves.
Okay, thank you for that, Paul. So second question, what type of examples of equity-informed public health action has been implemented in the past with the information?
That's a really good question as well, because that's one of our focuses in our in our agency, of course, is to try to look at everything with public health with an equity lens. And we're very fortunate to have two public health nurses that their portfolios are devoted to the social determinants of health. So all of our staff have access to our social determinants of health mapper, which essentially is mapping out all the different areas of the DI, all the different demographic indices that I showed you. And as far as I know, the policy is that all the different programming that we have in-house is all sort of put through the lens of what populations are to be targeted. From a climate change perspective, I know that when during heat events here, we do look at these maps and have a knowledge of where things like water stations or cooling stations will need to be opened.
Okay, thanks. Next question. Do you track changes in vector issues related to climate change with your systems?
Yeah, I mean, that's another really good question, and that's exactly when we start thinking about looking at tracking health indicators. At this point, we are using this tool as a real-time display, so we are not storing data. Would we like to? I will say yes, yes. Our IT team might have a little bit of a different answer because of the vast amounts of storage that we'll need. But we'll have to look at depending on where this application goes and the development of it. We'll have to look at different ideas. But the real value of the development of this was that we were able to just pull real-time data feeds from wherever that source of information is. We can show the earthquakes from the United States Geological Service, and we don't have to have the huge, vast storage of data that we would need to keep the historical. But in terms of climate change health indicators, the responsibilities for Ontario public health units is changing, so we may need to look at displaying those parameters in the future.
Thank you. So next question. Other than heat waves, what other public health issues related directly to climate change are being tracked?
I think that's a bit of a complicated question as well, because just as I said in the last question, we're not necessarily, we're not tracking it in terms of tracking events and keeping that historical data, but we can watch if there's a flood event. There's really nothing that if there's a possible health outcome and we can see a difference in environmental or meteorological information, I think it's fairly limitless what we could track per se. We could monitor.
Yeah, agreed. It's pretty generic.
So definitely cold events. We keep an eye on those.
Okay, thank you. Looks like it's the last question. How do you track air pollution impacts? Do you link real-time air quality data to the health indicators?
I think, yeah, I mean, again, I think similar to the last question, I think these are excellent ideas, and these are precisely the things that, we want to look at developing. And so we now are able to, you can download the data in real time. So, I mean, it gives the potential that we could use this app as is to download information over time. The goal in producing it was that real-time situational awareness. So during an event, using the system to be monitoring what is happening in real time. But you're absolutely right, a real focus of wanting to, developing the application is moving towards tracking things and seeing things, being able to display how it changes over time. Do we have that capability right now with this app? Not right now. Is it possible? Absolutely.
Thank you, Nancy. We just have one more question here in the room from Lydia.
Thank you so much, Paul and Nancy. Very, very interesting work that you're sharing with the rest of the country. I do have a question. Is it possible that the ACES and PHIMS systems and the data generated be integrated for coordinated use with emergency management programs outside of health?
Go ahead.
Paul and I are just looking at each other going,
yeah.
you answer that one. I mean, in terms of the IMS structure, the development of IMS is such that we all can, jump in and play different roles. I would think that it would be a perfect integration of systems, especially because, we have that real-time syndromic surveillance piece that, is lacking elsewhere. We've got the health outcomes, is the real value of the program that we have right now. And I know, and it's difficult to expand to different parts of the country because we've got the access to the acute care. But that's not to say that there's not other ways of accessing a different syndromic surveillance information in other parts of the country. Telehealth is a great example. Twitter, Facebook, there's lots of different means to having access to syndromic information.
Great. A follow-up question about that. With respect to situational awareness, there may be an opportunity for doing rapid risk assessment in emergency situations whereby emergency personnel do look to health for better coordination for recovery work. Is this something that the data could help toward lending some information and a better portrait of what's going on through rapid risk assessment?
Yeah, I think absolutely. We have access to all this information. It would be really great to work with somebody that would be willing to put that time into helping us, develop the protocols that would enable that.
Great. We'll await that.
Anybody on the call wants to volunteer, that'd be great.
Okay, so I think that's the end of our questions. Thank you so much, Paul and Nancy, for the great presentation. And if anybody has more questions, feel free to, email me directly. I can forward them to Paul and Nancy. Thank you.
Thank you.
Great, thanks.
Okay, thank you.
Thanks, Nancy. Wow.
Is that enough?